So what we're going to be talking about is a little bit about treatment escalation and treatment ceilings, do not attempt resuscitation orders, and a little bit about palliative care. So this is me. So I'm Akash. I am a medical registrar specialising in diabetes and endocrinology, working in West London. I run that website over there, mindthebleep.com, right at the top. And let's start by talking about what treatment escalation is, because if you want to explain it to what your patients, to your patients, what treatment escalation is, you also need to know it for yourself. I think this has become a much more topical conversation recently, secondary to multiple news articles from multiple websites. Essentially, with the COVID crisis, and I know all of you guys are going to hate me for saying the C word, but with the COVID crisis, there's been lots of articles that have been published about whether we're restricting patients from getting the right care, whether we're saying because there's not enough beds or equipment or whatever, we're making decisions saying, no, that patient doesn't deserve it because they're not good enough to deserve it. Well, actually, if you really think about what DNA CPR is and what treatment ceilings are, it's about the patient, not actually about the equipment. And so that's what I'm going to take you through, so that once you guys get that a lot, then you can explain that to your patients so that they are able to get that. And the way that I'm going to frame it is, as always, looking at a patient journey and a patient story. So you've got a patient who's deteriorating. And so it's a peri-arrest patient. The London Ambulance Service has arrived with a 58-year-old male who's presented hypotensive with type 2 respiratory failure. This guy's normally fit and well with no past medical history or drug history. And on assessment, you find that things are not good. His respiratory rate is 32. His SATs, despite being on 15 litres of oxygen, are 87%. His temperature is elevated, his heart rate is pretty high, and he's hypotensive at 77/54. And this is a bad situation. You don't need me to tell you that. And so what we're going to do is we're going to try and resuscitate this patient. We're going to try and give him lots of treatments to get him better. In a ward-based setting, some of those treatments that we might offer are intravenous drugs. So, for example, for this quite septic-looking patient, we may give him antibiotics intravenously. If he's anemic, we may give him blood transfusion, and if he's nutritionally depleted for a long while, then we may need to give him some nutritional support via an NG tube. These are the things that we can achieve in a ward-based setting. Beyond that, if despite our fluid resuscitation, our antibiotics and everything, he's not responding, we may need to escalate his therapy. And so that might be to HDU, where we can give vasoactive support. Often in these patients, it'll be inotropic support to squeeze those blood vessels, improve the blood pressure, or non-invasive ventilation in view of the fact he's got a type 2 respiratory failure, to help support his breathing, take over some of that work so that he's able to breathe more easily and help with that. Finally, if things still don't go well, we may consider escalating further to ITU. In ITU, these are some of the options that we might consider. We may think about haemofiltration, where we take over the job of the kidneys because they're not working. Or we may say that if our non-invasive ventilation, if our supporting breathing isn't working, we may need to take over the breathing, at which point we might put a tube down the throat with a ventilator to help take over that breathing completely. The other situation where we might involve ITU is following CPR. So after a successful round of CPR, we might have a situation where the patient has recovered spontaneous circulation, and we may want to take them to ITU. And so when we talk about treatment escalation, we talk about ceilings and treatment escalation, what we're saying is where on this spectrum are we going to put this patient and what's best for them? Treatment escalation planning is difficult. There's no question about it. Because there's lots of things that are possible. But just because something is possible doesn't mean it is right. The idea is that we're escalating treatment to support the body, right? All of the things that I told you are things that support the organ system. They don't fix them. And so if we recognize that simple fact, what we recognize is the fact that we need a patient who is going to recover, who is going to have reversible disease. All we can do is support the organs until essentially something reverses. Yes, we can give antibiotics to cure and nudge a patient in the right direction. But apart from that, all of the other treatment that we give is simply supportive. It doesn't fix or reverse the underlying issue. It just gives time for the patient's body to fix it. In terms of the things that we offer in HD or IT, let's just go through them in a little bit more detail so you know what they involve. There's vasoactive support, usually often not inotropic support, where we give intravenous drugs, usually through a central line. So that's often in the neck or the groin, the femoral line. And the idea is that it works on the heart and the vessels to improve perfusion by essentially squeezing them and making the heart work harder usually. What are the risks? Well, the risks are the complication of a central and or an arterial line. So this includes bleeding, because particularly in the neck, it can be quite close to the lungs. You may cause pneumothorax, can cause a lot of pain, distress. And then because we're squeezing things and making things often work harder, there is a risk of a heart attack, or the risk that we may lose blood flow to the extremities because we're squeezing the blood vessels and trying to get the blood pressure up to improve perfusion to the vital organs. By promoting it to the vital organs, we might sacrifice it from the less vital ones. There's always in any of these things, any of these strategies, a risk that it might fail and might not work. And it may simply cause prolonging of harm. Essentially, again, as always, if the body is unable to fix itself, if we're unable to reverse the underlying issue, then giving this will only improve the blood pressure, but actually won't change the outcome in any way. So we might be in a situation where we're doing this and it's just prolonging things, but it's prolonging the inevitable. There's also non-invasive ventilation. So this is again in a HDU setting where we might apply something like this, a tight-fitting mask on the face. And the way I describe it to patients is that it'll be like if you're on a roller coaster, or if you're sticking your head outside of a car and it's driving really fast down the motorway. That's the kind of pressure you're feeling on your face. That can be uncomfortable. That tight-fitting mask can cause pressure sores, discomfort, but the more important thing is it doesn't tend to work in those who are confused or drowsy or have lungs which are of poor quality, because what non-invasive ventilation does is it supports your breathing. It takes over some of that effort so that when you take a deep breath in, it blows air in, saying, do you know what, I appreciate you can't make that effort. I will help you make that effort for you. But if you are confused or drowsing for that reason, not able to work with the machine, it's not going to work. And also, if your lungs aren't simply able to oxygenate, it doesn't matter what we do to take the effort off. If your lungs aren't going to work, your lungs aren't going to work. So again, we need to make sure that we're selecting the right people for non-invasive ventilation, because if they're confused or they're drowsy, or there are people that aren't really going to engage with this treatment, so saying no, all it's going to do is not work, cause a lot of distress, and basically, once again, prolong harm and ultimately fail. Again, questioning, are we simply prolonging the inevitable? And then there's hemofiltration. Hemofiltration is basically where we're using, again, that central line to do the job of the kidneys. So instead of the blood circulating through the kidneys, we take the blood out, we clean it, and we put it back in. The risks of this are significant bleeding. It's possible that all your blood might be out at some point, not all of it, but a certain proportion of it, and the line might clot off, which means that you'll lose all of that blood. And so there's a significant risk of anemia and bleeding from this, particularly because we're giving anticoagulants, blood thinners, to try and get the circulation through this. There's a risk of hemodynamic instability because essentially we're taking fluid and blood out. There's also a chance that the underlying kidney disease might be irreversible. So if it is a situation where you've got a patient with significant CKD, you have to question, is this a patient who's suitable to go to dialysis? Bearing in mind that dialysis will be 3 times a week, they will have to go there, they will feel very rough in between, they'll have various medications that they'll have to tolerate. There's a lot of risks of dialysis itself. And so when you do the trials and you check which patients do well on dialysis, you find that those who are particularly elderly or have significant comorbidities essentially die sooner than those who are offered and given dialysis. And so it really needs to be the right person that we consider for this, because it's quite a hefty procedure to have. And then there's invasive ventilation. Invasive ventilation is where we place a tube down the trachea, down the windpipe, to blow air into the lungs. We take over the breathing. And by taking over the breathing, we need to make sure that we paralyze the body, that we sedate with propofol and other agents, and because they are going to need to tolerate the tube, and will then give artificial breathing. Ultimately, if you take that pressure off the patient, then often that can work for the right patient, but the difficulty is that they may never come off. They may never come off being intubated, because essentially, if you've got a patient who is unable to breathe, and that is why you have given them an intubation, unless you can reverse the reason for why they couldn't breathe, they will never be able to come off this. And so once again, you may be prolonging the inevitable. But also, once they've got this and you're essentially sedating them, they're not using any of their muscles, every minute of the day, every hour of the day, they're going to be losing muscle mass. So their ability to neurologically recover that strength to be able to fight infections, to be able to mobilize, to be able to get stronger and do those things that they want to do, can be significantly impaired. So they may lose their independence. And finally, because we're putting high pressures down into the lungs, we may squeeze all the blood vessels around the lungs, reducing your blood pressure. So once again, we may, by doing this, make things worse, because if you've got a patient who's also hypotensive, we may make things worse. And then finally, we've got cardiopulmonary resuscitation. Here, we're pressing hard on the chest. We're pressing so hard that it may be strong enough to break ribs. And we're going to be applying high voltage shocks to try and restart a heart that has already stopped. We know that this rarely works. Outside of hospital, we know that there tends to be often less than a 25% chance of having a successful outcome. In hospital, to be around 25, perhaps slightly higher chance. And that might be because of the patient selection cohort as well, because often when patients are in hospital, there's an opportunity to have these discussions and make the right patients for CPR, rather than have it as a default for everyone. But if you actually take a study of people out there in the public and say to them, look, let's say the heart stopped and we needed to restart it with CPR, what do you think is a chance that it would restart in an average person? They would say, well, 3/4 of the time it will restart. The problem with conversations about DNA CPR and treatment escalation is that patients can find it really, patients and relatives often have unrealistic expectations of how successful it's going to be. Essentially, what they don't realize is that when we do these things, there's lots and lots of risks involved. And so it takes a patient who's got quite a lot of reserve, because we're going to be taking away a lot of that reserve when we do all of these hefty procedures, which will put stress on every single one of their organs. And so what we want to do is we want to make sure that we do it for the right patient. We want to make sure that we do it in a situation where they're going to benefit from it and where it isn't going to prolong harm. With something like CPR, yes, you can reverse a heart that has stopped, but you really need to also be able to reverse the cause of the heart stopping. Anyone who's done ALS knows that we go through the 4 H's and 4 T's to work out what the underlying reason for the heart stopping is, so we can reverse that. Essentially, if the heart is the last thing to stop, everything, the patient, all of the other organs have stopped, restarting the heart is only going to get you to the point at which your heart stopped. And if we can't reverse any of the damage, any of the frailty of all the organs, there is nothing we can do by offering CPR, by trying to restart the heart. It will ultimately only stop again because nothing has changed. The last thing to bear in mind is that there could be an outcome which is fate that's worse than death. And so there may be a situation where we do this, where we are able to restart the heart. And when we restart the heart, we will intubate, we will give various vasoactive agents to push the blood pressure up, various medications to sedate, to paralyze. We'll be doing lots and lots of things. And the patient may well be in a lot of pain, a lot of distress, and also the relatives who look through this and say, oh, yes, the heart's restarted. Okay, we've got a chance, we've got a chance. But then quite quickly realize that actually nothing has changed and there's nothing we can do to reverse the underlying cause of why that heart stopped in the first place. And so we may reach a patient who just has a very prolonged death. An alternative might be that their brain may have shut down because of hypoxic brain injury and various other things. But we are able to extubate them. We're able to take that tube out, able to take them off all the agents, and essentially there'll be a situation where that patient is unable to respond, unable to have a conversation, unable to really have a life. And that might be a situation that's very prolonged until ultimately they develop an infection or something and they pass away. And ethically, there's a question of whether the patient would find that life worth living. And so often when we explain all of these, when we talk about treatment escalation ceilings, when we talk about CPR, we don't explain the fact that all of these situations are quite possible, actually quite common. And so that's why for any patient, we will do everything that we possibly can that is likely to benefit the patient. But ultimately, what we aren't going to do are things which aren't going to work, which are going to cause more harm, which are going to be distressing, not only for the doctor or the healthcare professional looking after the patient, but the family, the patient, everyone involved. It's really difficult. So when should we consider a DNAR and treatment escalation plan limitations? Firstly, when the underlying condition is irreversible and risks death. Because essentially, if the condition is irreversible, there is nothing we can do to prevent it, and resuscitating the patient will not in any way cure the thing that's irreversible. If a patient says with capacity that they don't want it, and they may have their reasons for not wanting it. And then finally, when the risks of CPR outweigh the benefits. And I think the Rockwood Frailty score, which is this, what you see on your screen at the moment, is helpful to appreciate the kind of patient who doesn't have the ability to deal with the significant stresses all of this treatment is going to put on them. And so if you get to the point where you've got somebody who is, particularly if they're 6 or higher, you may well have a situation where the patient just doesn't have that physiological reserve to have any benefit from CPR. Each patient has to be discussed individually, because there may be certain situations where, do you know what, we could give them a little bit of help from HDU or ITU, and we can reverse something, or we can get them back. But ultimately, if the underlying condition is irreversible or it's unlikely to work, then it's not the right thing to do to offer this to your patient or your relatives, and giving them false hope and giving them a prolonged and protracted death that's painful is not the right thing for your patient. And so we need to be very clear with what we're going to offer. What we're not going to do is commit a patient to a slow, painful death where interventions aren't going to work. We will, though, do every single thing up until that point to make sure that they don't get to a situation where they need where they need HDU or ITU if it's not appropriate. So putting a DNA CPR or putting treatment escalation ceilings doesn't mean we're not going to treat. It just means we're only going to do treatments which are useful and helpful. But if in a situation where we don't have any treatment that is going to work, we may want to let them die. We want them to die without pain and with their dignity. And that's where we introduce the topic of palliative care. So these are the pillars that we think about when we talk about palliative care. We talk about stopping interventions which are not useful for the patients because they're going to cause distress and harm. We talk about symptom control. There's lots of symptoms which exist when a patient is dying, and we need to think about treatments that will help with each of those. There's also psychological support for managing those emotions and those stages of grief, not only for the patient, but for relatives and all the other things. There's planning for a death. There's religion and spiritual care, so thinking holistically about the patient and thinking about all the things that are important for them. And then finally, thinking and considering the place of death. When you think about palliative care, what you need to think about is the patient in front of you. Would I be surprised if they passed away in 6 months or a year? And often the answer to that is no, I wouldn't be surprised. They're so frail, they've got so many medical problems wrong with them. It would only take one severe infection or one heart attack or one blood clot or one bleed, and that patient would ultimately pass away. Having all of these conversations at that moment when it's so stressful for the patient, so stressful for everyone involved, is difficult. And so having these conversations slightly earlier, having relatives that know what their mum or their husband or their wife wants can really be helpful to make sure that we have these discussions early and we do the things that that patient wants. This is very difficult when you are that relative and haven't had that discussion, and then you're told, well, we could consider giving another round of antibiotics, we could consider doing all of these interventions. And you're in a situation where you're like, it's very difficult to say, no, these interventions aren't appropriate. All they're causing is distress, and they're not actually treating or reversing anything. They're just delaying the inevitable. It's very difficult as a relative to say that, because ultimately what you feel like you're saying is, I'm letting my loved one die. And so that's why it's really helpful to have these conversations with family members, to prompt these conversations, whether you are called out to a patient who you look at and you're like, you look very frail. Start considering these conversations in the community. It takes a short second to say, why don't you talk to your GP about this? Why don't you talk to your doctors about this? Why don't you talk to any other healthcare professionals that you're seeing about this? Because if we're all on the same page, then it's much easier for the relatives, the patient, the healthcare team looking after the patient. It just works a lot better for everyone. Let's talk about each of those interventions in just a little bit more detail. So stopping interventions. Essentially what we want to do is we want to stop medications that may not be helpful. So preventative drugs, we're thinking things like statins, ACE inhibitors, things that, and also glycemic control, things that help with your diabetes. Ultimately, it does not matter if these things are not given, if essentially they reduce your risk of having a heart attack in 10 years. If your survival was only 6 months, having that burden of medications, it's just not right. Similarly, there is no point doing a colonoscopy to have a look because the patient's anemic for a cancer if they only have a survival of 3 months anyway. Picking up that cancer is not going to change that patient's journey in any way. We need to think about their current treatment and think about what's appropriate. This can be very challenging. Intravenous drugs, for example, antibiotics, do we continue giving them or do we stop them? When do we stop them? Fluids, but essentially for most of our patients, when they're so ill that they're not drinking fluids and they are in a terminal phase, they are not thirsty. Fluid is taken as so much of a basic human right that for relatives and for other people can be really difficult to withhold fluids. And so we need to think about, is this the right thing for the patient, and explain it quite carefully and clearly that actually when the body's shutting down, they don't feel thirsty. They don't feel like drinking, and that's okay. Putting in a cannula after cannula after cannula to give those fluids is very distressing and uncomfortable. Next, there's advanced care planning. So we need to think about those patients who keep bouncing into hospital, you keep getting called when you're the ambulance service, or keep getting called when you're the GP. We need to manage the expectations of the family of the patient, because ultimately them coming to hospital and having another course of antibiotics, which help in no way, patient goes home, develops the same infection, comes back. Ultimately, that is not a way that really anyone would want to die. And so it may not be the right thing for our patients. And so we need to have those discussions about advanced care planning. If this happens again, do you think that that's the right thing for this patient? Do you think that's the right thing for us to do? And then there's symptom control, and this goes hand in hand, because essentially it can be really distressing having a patient, particularly when they're at home, having a relative pass away. And you can look at them and you can see that they're so distressed, and it can be really uncomfortable, and the temptation is there to bring them into hospital. But then they're waiting in A&E, then they're cannulated, they have blood tests, they have another round of antibiotics. It's not often the right thing for the patient. And so it can be really helpful if we do have a patient who we're thinking is starting to get to the point where they may pass away very shortly. It's about symptom control and making sure that we anticipate their needs, and hence these are called anticipatory drugs. And giving them early can prevent your patient from getting it's like what Andrew said before. We've only got one chance to get this right, and we've got to make sure we get this right. And so by giving them all these medications ready to hand when they need them, it can prevent them from getting all of these distressing symptoms and passing away in a very uncomfortable and horrible way. And so we'll think about medications for pain like opiates, or agitation like benzodiazepines. Often we give things like morphine or oxycodone. For benzodiazepines, midazolam. For nausea and vomiting, there's a whole selection of things that we can give, from cyclizine to ondansetron, to help with that sickness. And then there's also noisy breathing and the secretions, which patients can sometimes get distressed coughing on. And there's medications that we can do to dry up those secretions, like glycopyrronium. We also need to offer psychological support. We need to recognize that dying is very difficult for not only the patient, but for everyone else around. And so it may take a while for people to accept the fact that they're passing away, and they may go through all those stages of grief you hear about, from denying it to accepting it, to feeling horrible about it, to getting angry about it. And they need support through all of those stages. The process of death itself can be very psychologically draining. And for the patient and for relatives, the idea that somebody might not be there in a day, in a week, in a month. And then after death, it's about helping that family cope with what's happened, process what's happened. It can be, for example, very distressing if their loved one passes away quite suddenly or quickly. But also equally, it might be very distressing if their loved one has died at home, or not got the kind of best death process. Their symptoms were very poorly controlled. They didn't get all the support they needed. All of these things can be very distressing, and the family may well need help with this. Then there's also planning for death. And it can be really helpful to kind of prompt these things so people can discuss them, feel more comfortable raising them. Funeral planning, financially, what it will involve. Care. So thinking about, as the patient themselves, what am I going to do about all the family I'm going to leave behind, the friends that I'm going to leave behind, and all the duties that I usually have? Who's going to do them? Financial planning. So having a will, or what you're going to do with your properties, with your belongings, any kind of passwords that you might want to pass on. Those are all things that you might that you want to consider early when you're ready and able to have those conversations. Next is religion and spiritual care. And this often gets forgotten, and I can't stress how important it is, because actually, ultimately, this can be one of the most comforting things for a patient. They may be religious and want specific religious processes, praying, ceremonies, and other things that will help them come to terms with what's happening. So this is really helpful in certain situations. It may help with decisions about ethical issues in DNA CPR. It may also be a hindrance because often some people may feel that we're making decisions to let somebody die. But ultimately, if we do explain it, that at the moment that we are considering a DNA CPR, the heart has already stopped and the plan is to restart it. Arguably, you could say that we're going against the natural history of things by intervening and restarting things. It may also be comforting to think about what there might be after death, whether there's a place that they might go to, whether there's a heaven, whether there is some sort of other plane that they might go to. The fact is, it can be really helpful and comforting to think that this isn't all there is in life. The next thing to consider is place of death. And so there's three main places of death that a patient may have as options. Hospital. So some people might find that very noisy, busy, uncomfortable because of the bed, what's happening around them, the conversations, the fact the family can't visit as often. But they might also find it safe, calming, and supportive. They know that whatever they need will be available, any medications that they need, any support they need. Or they might have such an intense use of hospital resources that actually a hospital might be the right place for them at that point. Next, we might consider hospice. So hospice, for example, might be very kind, very caring and thoughtful. Everyone's going through the same process, and so they're helpful and they're equipped to kind of deal with that and prompt those discussions and have those conversations with staff who would regularly have these conversations. But also, it might be really upsetting to be in a place where everyone is dying, or everyone is having symptoms associated with that process. It might be very, very scary, very emotional. One of the helpful things about hospices, though, which people often don't know, is they can actually run kind of outpatient services, where to some hospices you can go quite early on and have specialists, palliative care teams, nursing teams and doctors are incredibly amazing at dealing with symptoms. So it can be really helpful booking them into these kinds of things where they can see people and get help and support from their symptoms. It doesn't mean that they're ultimately dying immediately or in the next few months. It just means that they need a specialist to help with all of that. And then there's home. So home might be comforting because of the warm and familiar environment. You are surrounded by your loved ones and everything is warm and fuzzy, but it also might be a really horrible place. Some people might say, I don't want to do that to my relatives. I don't want to die in front of them. It might be very difficult for the relatives too, because they've got to look after you. They've got to help and support you. They may feel unprepared. They might feel frightened. They might get to the point where if the patient is passing away, they feel so overwhelmed that they call a hospital, undoing the patient's preference in place of death. And so it's really important that we consider all of these aspects and have an open and honest conversation, bearing in mind that it may not be possible for them to be at home if they require things which we can only give in a hospital. And there may not be space at a hospice. And so whilst there are all three of these aren't definite possibilities, it's helpful to discuss through them and see what patients prefer. But ultimately, we'd have to be open and upfront to a patient, say what you prefer may not be possible when it gets to the end because of how quick things might be or because of interventions you might require. But ultimately, we will try and support you with whatever decisions you make. So let's talk about all the things that we've talked about. Treatment escalation. I think the key message is just because this is possible doesn't mean it is right for a patient. If the patient is independent, fit, well, has minimal comorbidities, yes, of course, it's the right thing for the patient, because ultimately we will give that treatment, the patient will get better and they will live a fulfilling life, hopefully. There's still a chance it might not work, but the chance of it not working is far outweighed by the benefits. But there is a massive cohort of patients that's much larger than the patients for whom it is appropriate, that it is not appropriate to completely escalate their treatment to things which aren't going to work and are going to cause distress and harm. And so when you have a patient in front of you, think about what their functional status is, think about what their frailty is, and think about whether you think there's a chance that this patient might pass away in the next 6 months to a year. And if that's the case, think about treatment escalation and bring up those conversations early. The next thing specific to consider is DNA CPR. DNA CPR is an absolutely horrible process for patients in which rib breaks, they can get quite powerful shocks. It's distressing often for relatives to observe. It's distressing for everyone. And ultimately, there is a massive difference in what people expect of it to work, how often for it to work, which is about 75%, and how often it actually does work, which is the complete opposite at 25%. And so we need to think about when DNA CPR is appropriate in those irreversible conditions, when those patients wish for it, but also when the benefits of not doing it outweigh the risks of doing it. And so once again, we need to think about, would you be surprised if this patient in front of you passed away in the next 6 months? And if you wouldn't be surprised, well, then we need to have a conversation and discussion about it. Ultimately, you may make a discussion and say it is appropriate to do, it is appropriate for CPR. But ultimately, if you think the patient is likely to die in the next 6 months, it's likely they've accumulated enough comorbidities, enough frailty to the point where CPR simply isn't going to work, because we may be able to reverse the heart, we may be able to restart the heart, and we won't be able to reverse the underlying problems, and they won't survive the ITU stay while we try to reverse those problems. Giving false hope to the family, but also being quite distressing for them. And then finally, we need to think about palliative care. And when it comes to palliative care, we need to think about holistically all the different kind of domains, from stopping unnecessary interventions, to thinking about the psychological and spiritual support, to thinking about symptom control, and also considering the place of death and the kind of almost plan for when they die and when they have their funeral, and dealing with all their duties that happen after they die, and supporting not only the patient but also the family through all of that emotional journey. We need to make sure to achieve all of that, because that's a lot to do, isn't it? We need to make sure that we do have those discussions early. So ultimately, if we get to the point where we think a treatment escalation ceiling is appropriate, where a DNA CPR is appropriate, we also need to strongly consider is palliative care input or discussions appropriate, because it's much easier and much better to have these conversations early on when the patient is well comparatively, to right in the moment when I've often had to call at 3 a.m. in the morning and tell them, oh no, things have gone really badly. We couldn't have predicted it, but they've had a heart attack or a fall or a bleed or a really bad chest infection that has gotten a lot worse. And having those conversations at 3 a.m. when you're really distressed by all of that information, it's really difficult. So having these conversations early is the best thing for not only our patient, but our relatives too, but the patient's relatives too. And that concludes all of the things that I wanted to talk about. So a shameless plug, which is my website, and also you can follow me on Twitter at MindTheBleep, or on Facebook at MindTheBleep, or on Instagram at MindTheBleep. And what we have over 170 articles on various topics, including DNAR, palliation, so you can learn about all of these aspects in a little bit more detail if you'd like, and they're all completely free.